So Simran, perhaps you can talk a little bit about everolimus and the variant RADIANT studies that led to approval in different indications.
Sure, yeah. So for our audience, everolimus is an oral agent. It's an mTOR, a mammalian targeted rapamycin. It's a daily dose that's taken, as I mentioned, orally. It's probably the most studied targeted agent we have in neuroendocrine tumor today. There's been numerous large randomized control trials showing its efficacy. The first one was the RADIANT-3 study, which was specifically in pancreatic neuroendocrine tumors, which showed a significant benefit in progression-free survival for patients with pancreatic neuroendocrine tumor who were taking everolimus. Subsequently, there was recently the RADIANT-4 study, which really looked at the entire GI subgroup as well as the lung neuroendocrine subgroup and showed an advantage. This really led to everolimus being the only approved therapy for lung neuroendocrine cancers, as opposed to GI and pancreas, where we have other options. Really, our only approved option at this time is everolimus. It is an oral agent, so that offers a bit of patient convenience, but it does have toxicity that I think needs to be managed. Things like mucositis, some mild fatigue, diarrhea. There's some endocrine abnormalities, including hyperglycemia. We got to watch the cholesterol and the lipids on it. And then there's some rare side effects as well, such as fibrosis in the lungs that needs to be monitored. So it does require monitoring, however, and I think the toxicity can be managed, but we have to ensure that we're active participants in that care.
Right. I think it's important to also consider the differences in population and outcome of RADIANT-2 versus RADIANT-4. RADIANT-2, of course, was a randomized study of octreotide plus everolimus versus octreotide plus placebo in patients with neuroendocrine tumors and history of carcinoid syndrome. So it was mostly a study, I think, of fairly typical midgut neuroendocrine tumors, although there were some non-midgut tumors there. And that was a study that just fell short of statistical significance. And of course, even on the placebo in this relatively indolent population, the median PFS was quite long. Whereas RADIANT-4 looked at non-functioning tumors, they required a relatively short interval at which time they had to have disease progression. So it turned out to be a much more aggressive population with a median PFS of only 4 months on placebo, and turned out to be a really positive study. My personal take-home message from that would be that everolimus is probably more appropriate for your relatively aggressive non-midgut nets rather than midgut nets. But I wonder whether you have the same conclusion, or whether maybe it's more of a non-functioning versus functioning thing, or aggressive versus indolent. How do you see that?
So it's interesting. I'd say that I probably disagree with you slightly on your interpretation. When we looked at RADIANT-2, there were a number of factors that were involved. I mean, that was early on, when it was one of the first randomized trials we ever did in neuroendocrine cancer. And we were really learning in this heterogeneous population of how do we do randomized trials. So, I mean, as you know, there was imbalance between the arms. And I think having a placebo arm that receives somatostatin analogs, realizing that we now know that there's probably an anti-proliferative effect, maybe also diluted the effect that we saw. And as you mentioned, you know, it was very close to being positive. So, to be quite honest, I realize that we have a negative study in RADIANT-2, but I find that everolimus is probably going to be effective for most neuroendocrine cancers. Certainly for lung, we have few other options. Right. Your comment about the midgut, I think it's probably correct when we look at the subgroup analysis from the GI subgroup. So certainly I would start with somatostatin analogs. And then, you know, with the recent, as we're going to discuss, you know, the recent introduction of PRRT, I think, you know, we have a number of different options that we want to consider, but I think it's definitely part of our armamentarium, even in midgut tumors, right. Would be everolimus.
Right. And of course, it's important to select patients appropriately.
Yeah, and take patient preference into account as well. Yeah.
How about sunitinib, Sutent? Where do you use that?
So we have a lot less data for sunitinib, but we do have good data in the metastatic pancreatic neuroendocrine tumors, very similar to everolimus. We know that, in fact, it's another oral agent that has a good effect in those patients with pancreatic neuroendocrine tumor. Again, you know, we have to understand toxicities. It can cause a bit more fatigue. It can cause some hypertension. So again, and hand-foot syndrome, absolutely. So I think it's important that we sort of tailor, if we're going to use everolimus or sunitinib for our pancreas patients on an individual patient perspective, to try to give the right treatment to the right patient.
Yeah. It's really striking how similar the randomized phase 3 Sutin trial was to Radiant-3 as far as median PFS basically doubling from about 4 or 5 months on placebo to about 10, 11 months with treatment. So the outcomes were very, very similar. And sometimes we can use comorbidities to help choose between sunitinib and everolimus. So patients with diabetes, for example, you may want to consider Sutent. Patients who have history of cardiovascular disease or hypertension or bleeding diathesis, you may want to consider everolimus.